Welcome to Attikon University Hospital. My name is Karamasis. I will be working with my colleagues Labis Varlamos, Valia Dragona. We'll have the support from our nurses, Stamatia, Leka, and Aspa, and our technician, Yota. The purpose of the recording today is to demonstrate how we assess microvascular function by using bolus thermodilution. I will talk a bit about the patient. We have a 56-year-old woman who's complaining of typical stable angina. From her past medical history, she is a smoker and she has a positive family history for coronary artery disease. I think it's the time to show the coronary angiogram. Let's see the first image, the PA caudal. As you can see, there is no disease. There's not even athyroma. Let's see the PA cranial view. And we can see also the right coronary. The previous one, okay. I would say this is a typical candidate for microvascular assessment since she has symptoms and she has a positive ischemia test. So we're going to proceed with bolus thermodilution. And the first thing that we need to clarify is that we need some special equipment. We need a pressure wire that has a thermistor as well. This pressure wire is supplied by Abbott. And we need a special software, the Coroventis, which is going to record the pressure traces and the temperature traces. Let's change the screen to the Coroventis screen. As we can see, we see the pressure trace from the aorta and the pressure trace from the coronary wire, which we have placed at the distal third of the coronary artery. We can discuss with the panel where to place the wire, but the usual guidance is to place it at the distal third of the artery, or at least to have 60 millimeters difference from the guide catheter. We started the procedure as we do with any physiological measurements. We gave nitrates, 200 micrograms of nitrates, and then we equalize the pressure wire, and you can see the equalization position on the angiogram. The wire is just distal to the tip of the catheter because the pressure transducer and the thermistor transducer is at the proximal part of the radiopaque part of the wire. And now we'll start with the measurements of bolus thermodilution. And now we can start. Before going to the thermodilution screen, we'll do a resting measurement. So Valia, please go to the RFR screen. RFR. Okay. And we can pressure the RFR button so that take an RFR measurement. No? As you can see, and as we expect from the angiogram, the RFR is strongly negative. We'll have an FFR measurement as well when we do the bolus thermodilution. Let's go back to live and change the live and change the screen to CFR IMR. Okay, you see the screen, and you see that now on top of the pressure curves, we have a blue line, which is the temperature curve. We'll zero the temperature, and this is, Valia, we're going to zero the temperature now. The zero button, it's there, okay. And this is our baseline, which is the temperature in the coronary vessel, which is the temperature in the body. So we'll start now with injecting 3 ml of normal cell line. We'll start with some test injections, and please, Lab, go on. And you can see the curve that is created. Let's do another one. Okay, and now we can press start and start the actual study. Inject now. Δεν θες να κάνεις κάτι, απλά ο Λάμπης το πατάει. There is an error, as we can see. It was a slow injection, so inject now, inject another one. Inject now. And inject now. Okay, there's a discrepancy in the measurements. I think the second one is an outlier, so we're going to change it. Just press on this, press on it, okay? And now let's take it again, inject now. As we saw, the software immediately recognized the discrepancy and highlights the average as yellow. Now that we don't have more than 10% discrepancy, we see that the average of 3 is not yellow anymore, and we are at the time that we can proceed to hyperemia. We use adenosine. Το ξεκινήσει. Να ξεκινήσουμε, ναι. Adenosine infusion to induce hyperemia. There are other ways to do it. You can use bolus adenosine, you can use bolus papaverine, but we prefer this. Obviously, we're going to assess the kick-in of hyperemia by monitoring the blood pressure, the ECG, and more important than all, the symptoms from the patient. Κυρία Κατερίνα, μπορεί να νιώσετε κάποια συμπτώματα, πόνο στο στήθος ή δύσπνοια. Αν το νιώσετε, μας το λέτε, γιατί σημαίνει ότι το φάρμακο που δίνουμε έχει ξεκινήσει να λειτουργεί. Πώς αισθάνεστε? Ωραία. Any changes in the blood pressure?
Slightly up.
Okay. So what does happen when you use adenosine IV is that when we start having hyperemia, there is initially an increase in pressure and then a drop. And I think that now she is experiencing something, so we'll start doing the injections during hyperemia. It's the same process. We inject 3 ml of normal cell line. And as you can see, the transit time is much faster. You can see this curve. Είναι αυτό που περιμένουμε, μην ανησυχείτε. Inject now, Labi. Είναι μέρος της εξέτασης. And inject now. Ωραία. There is no discrepancy. The measurements are very good. We can stop adenosine. And you can click and save. Okay. So that was all. As you can see, it's a quite simple process and fast. It doesn't take time. As you can see, the average resting transit time is 0.67. The hyperemic is 0.14. That gives us a completely normal CFR of 5 and an IMR of 13. It's a negative study for microvascular dysfunction. You can see also in our screen that we have an FFR measurement, which is again, is what we expect is a normal study. Another method to calculate or better to assess microvascular function is continuous thermodilution. In order to perform continuous thermodilution, you need again the same temperature and pressure wire from Abbott. You need the Karamasis system, but what you need on top, you need a microcatheter, a special microcatheter, which is called Rayflow, and an infusion pump. This microcatheter has 4 holes close to the tip and creates 4 jets of cell line when you infuse, and this cell line induces hyperemia. What we have to do now, in order to perform continuous thermodilution, is to place the Rayflow catheter at the very proximal vessel that we want to investigate. We see that with a faster flow rate, the temperature drops much faster. It goes down to 0.45, 46. We'll give it a few seconds to let it stabilize. At the same time, we see that there is a separation between the pressure curves. We see the PA, which is the red curve, and the PD, which is a green curve, and we see that there is a slight separation. This is a sign that hyperemia has been induced. Okay, it looks like that the temperature has stabilized there. So the only thing that I have to do is just pull back the wire. And now we'll stop. Not stop the infusion, not stop the recording. Stop the infusion, please. And when the temperature goes back to 0, we're going to stop the recording. Okay, it's almost 0. We can stop it, Valia. And this is what you get with continuous thermodilution. You see on your screen absolute flow and absolute resistance. Now we're going to finish the recording. I'm just going to pull back the wire and the microcatheter. And we're going to take a last shot to make sure that everything is fine. Are you ready, Labis?
Yes.
Okay, as you can see, the vessel has not been affected at all. The flow is normal. This is a very safe procedure.
Dayan, if you allow a comment, I'm not going to talk at all actually about continuous thermodilution because Tom, who's an expert, is going to say much more. What we want to demonstrate with this case is how simple it is to measure bolus thermodilution and how fast. Actually, this was real-life timing. On the other hand, as you saw, there's a variability. This is what happens in real life. You get measurements that are outliers, and you have to correct them. There were excellent comments before about the curves and how the curves should superimpose. We saw that this happened much more when you have hyperemia, so the measurement is more standardized when you have hyperemia. Is more difficult when you are at the resting state.
Maybe one question, because we talked a bit extensively about inducing hyperemia. What is your threshold? Here in the video, you waited for chest pain, for some symptoms, for IV, but this doesn't happen always. I mean, you can see the separation of the curves, you can have a chest pain, but you may have neither of those two. So how do you know that you achieved hyperemia with the IV?
That's an excellent question. As you said, it doesn't happen all the time. When chest pain starts, I think it's the time to take the measurements. And this is what happened to this lady. Very quickly, she developed symptoms. She started complaining of symptoms. That's why it was. I spoke in Greek. I was explaining to her what's happening. So when the symptom starts, it's a time to take the measurements. If you don't have symptoms, you monitor the pressure curves. And you wait for a reasonable period of time. Maybe 2 minutes.
4 or 5 minutes sometimes? 4 or 5 minutes sometimes?
I will say to maximum. What I do if I don't see any symptoms or separation curves after 2 minutes, I do a bolus to see if actually the IV infusion is working and see if there is difference with the bolus, because the bolus is going to work. It's not good, as we were discussing before. In my opinion, it's not good for measuring CFR and IMR. Maybe it's better in expert hands like Javier's hand. But in general terms, continuous produce a more stable state of hyperemia, and I think it's easier to use.
Maybe a comment on that. In the vast majority of cases, you have the drop of pressure, you can if you wait 2 or 3 minutes, you can get the result that you want with intravenous adenosine, pretty safe. And
Simone?
No, just what I do is after 2 minutes, if I don't see anything, I start with the first bolus, hyperemic bolus, and if what happens is what happened in the case, so you have a very short time, then you know, yeah, you're okay.
That's good. That's a good tip. Okay, thank you very much. Tom, please tell us more about this novel technique.